All right, so continuing our discussion of race, illness, and medicine, this brings us to questions of the role and place of race in medicine itself. So this brings us to the Bidil controversy. So Bidil is a drug designed to treat heart failure, specifically targeted to people of African descent. Now there are several arguments for the creation of this drug. So Bidil is considered a step forward in reducing racial divisions in health. Many studies have focused exclusively on European biology as normal and do not account for the heterogeneous nature of American society. A drug specifically designed for African Americans may balance the research design shortcomings. Now, this is in line with the assumption that African Americans have differential racial biology. So poor health is the result of biological differences that need unique treatments tailored to them. Now, an argument against the creation of Bidil was, again, being the largest, that the nature of human biological variation does not coincide with race, but I will not reiterate all of those details again. Now, other arguments is that race reduces the nuanced and complicated factors that affect health and healthcare, so it ignores factors of socioeconomic status, discrimination, gender, and access to healthcare overall. Now, in particular, the Bidil was originally developed to treat heart failure in all people. However, the drug was rejected for development. The targeting of African American patients seems to be simply a marketing campaign for funding, and there is not enough research to support its claims as being a beneficial drug for a specific biological target group. Now, there's a study on genes, race, and culture in clinical care that investigated clinicians' understanding of race and its utility to diagnosing patients and establishing treatment plans. Now, its findings were that an overwhelming majority of clinicians interviewed indicated that it was extremely important to consider race when interacting and diagnosing patients. However, most were unable to clearly define what race is and how to accurately identify individual race. Often, they relied strictly on visual cues. Now, race itself was used often to make assumptions about behavior and socioeconomic status, things as disease susceptibility and particular health risks, as well as treatment plans in terms of drug cost, treatment follow-through, and effectiveness. So the conclusions of this study was that race was often used as a biological proxy to act as a placeholder for more detailed information on family history and an individual's health status. As such, it was severely impacted the treatment for racialized patients. So the study argued that clinicians should not modify care for racialized patients, but instead identify relevant health factors specific to each patient, no matter the race.